segment, and our chairperson, Dr. Asha ma'am, for chairing the previous segment. We will move on to the next segment. Dr. M.S. Seshadri sir would continue to chair this session also. I want to invite Dr. Samuel George Hansdeck sir to join the chairperson area. Sir is the professor and head, Department of General Medicine, CMC, Vellore. He's a founding president of Indian Society of Lifestyle Medicine and former president of Asian Society of Lifestyle Medicine. He has a vast teaching experience and numerous publications and contributions to book chapters and modules. He started the postgraduate diploma in lifestyle medicine in CMC, Vellore. His areas of interest are lifestyle medicine and remission of metabolic diseases. Welcome, sir. The next talk is Updates in Interventional Pulmonology by Dr. Richa ma'am. Dr. Richa Gupta is Professor and Head of Department of Respiratory Medicine at CMC, Vellore. Ma'am has multiple publications in various international and national journals. She started and established the chest ultrasound services in the year 2008 in Respiratory Medicine Department. Ma'am has performed successful serial bronchoscopic lobar lavage, a new treatment for pulmonary alveolar proteinosis. Her areas of interest are pleural diseases, chest ultrasound, and medical thoracoscopy. So today's topic is updates in interventional pulmonology. Welcome, ma'am.
Good morning, everyone, and thank you for this kind invite. So in next 20 minutes, probably what I would do is to see what does interventional pulmonology encompasses, a brief preface about the latest in field and some probably real world clinical cases, because that will tell us how and when we should be acting on these patients. Now, 20 minutes, I would say, is really, really very less to define or put the updates in IP, because we did 2 months back, we did 2 full-day conference on interventional pulmonology, and we still felt that we left so many topics. Anyways, I tried to do whatever I can. What does interventional pulmonology means? It is basically focuses on minimally invasive technique for the diagnostic, treatment, or palliation of multiple diseases of the chest. Now, this branch has come up a big way in last decade. It is divided into basic and advanced. Basic is like bronchoscopy, BAL, biopsies, diagnostic thoracentesis, EBIS, and closed or image-guided pleural biopsy. When we talk about advanced, it basically more focused on complex diagnostic procedures and mostly on palliative and therapeutic approach to these things. So I've divided into 4 columns like airway, mediastinum, parenchyma, and pleura. And let's see how it is making difference in the life of the patients. I have a 44-year-old male non-smoker who presented to ED with complaints of noisy breathing for 2 months with significant worsening in last 1 week. He's a known diabetic. He also has history of intubation for 5 days only for a bronchopneumonia and thyroiditis 2 months back. And after his discharge, from 5 days onwards, he was having this noisy breathing, but was not significant, or he didn't give any importance to it. So he came to the ED department. He has biphasic stridor. And so this is the CT scan. In the interest of time, we have cut down these CTs, and it is running a little fast. So if you could see, there was a narrowing of the trachea, upper trachea. Now, what we will do next in this patient? What are we going to do next? What are the options we have? Do we call the CTBS people, say there is a narrowing, can we do cut and anastomosis? Or do we call the ENT people to do a tracheostomy? Now, both the things are possible depending on where the lesion is. If it is low down, then it will be difficult. You won't be able to do anything with the tracheostomy. So what was done was we did a rigid bronchoscopy. The first picture is the one which actually just 2.5 centimeter below the vocal cord. This was the lesion. And then what we did was we used the electrocautery knife, did a tri-radiant cuts, and then you can see the subsequent pictures. This was followed by balloon dilatation of the area, and this is post-procedure we were able to go into the trachea. So initially, we were not even to pass our normal adult bronchoscope or even the pediatric scope. But after the procedure, this is what we could achieve. And this is the final outcome. The picture on your left is actually post-procedure 5 days. Once the healing has happened, after that, chexoscopy was done, and we can see the difference. So we have prevented surgery on this patient, and we have prevented tracheostomy as well, which will certainly require longer care. Let's look at another case, a 65-year-old male, non-smoker, having recurrent episodes of cough and expectoration for 3 years, has history of hospitalization for pneumonia of right lower lobe twice in last 1 year. So in his second admission, a wise gentleman did an bronchoscopy. A pulmonologist was called in. An endobronchial lesion was seen in right lower lobe. So he was advised, when they did it, they felt that it is involving significant, lower lobe, so it should be taken as lobectomy. So they came to CMC for second opinion. This is the X-ray. You could see there is some opacity in the right lower zone. Let me run through the CT scan. You would see that lower down, there is an endobronchial component as well as post-obstructive, there is collection. What we do in this patient, how should we do is, what we do it, we went in with an intention that let's see, because we were not very sure on the CT scan itself whether it is a sessile lesion, whether we would be able to remove it completely or it has a broad base. So we went with an intention to take it off completely. We did a rigid bronchoscopy. This was the lesion in the right lower lobe. This was removed completely with multiple modalities, but I would say electrocautery snare and cryo was used, and the histopathology came as hematoma, which is certainly a benign condition. And this is the X-ray of that person after 1 month, because we asked him to come for follow-up, and this was exactly the area from where the lesion was removed. So in this gentleman, we prevented the surgery, and it came out to be benign. So certainly, he has a good life. I mean, we are not looking at anything which is malignant or things like that. We have a third case, a 55-year-old male, smoker of 20 pack years, known diabetic and hypertensive, again presented to ED with some dry cough, shortness of breath for 2 months, then worsening breathlessness with noisy breathing. He also have weight loss of 12 kg. Examination-wise, he was having stridor. And this was the CT scan, which is really scary to see. We see the mediastinal lymph node is big mediastinal lymph node, which is significantly compromising the airways, the trachea, as well as the bilateral main bronchuses. This was an emergency, actually, so we have to rush the patient to theater immediately. Again, I'll just wanted to, the picture over here, this lesion we are seeing in the right lower lobe, not in any of the main bronchus or the trachea. I'll just show you the initial, this is what we were able to see. The distal trachea had so much of significant external compression with the tumor, and it was involved. We were not able to go into the left main bronchus as well. And so first thing was to secure the airways. We secured the airways, and then we have to put the stent. So we put a metallic Y stent because both the bronchus were also involved. So it is kind of making a new trachea or the airway for the patient. Now this patient, because radiologically, it was very much suggestive of malignancy, and there was no way for us to do a silicone stenting. We have done this. Now this area, what we are seeing, there was the tumor actually, which I have shown you the picture, that was also removed. The histopathology came as squamous cell carcinoma. A 34-year-old lady diagnosed as adenoid cystic carcinoma of trachea under treatment with medical oncology, again presented with worsening breathlessness, noisy breathing, and unable to lie down for 7 days. This is a CT which is again not very good. And if you could see, not only the tracheal lumen is narrowed, but there is involvement of the tracheal lumen as well. And this lady is having metastasis also to the parenchyma, but she is surviving on the medications since 21. She was diagnosed. And this is the time she came to us. with the, she was referred because of noisy breathing and difficult to breathe. What we did was rigid bronchoscopy, and this is what the bronchoscopy picture would look. It was really, really bad. It was bleeding, and we have to secure the airways. So in this patient, what we did was we did a rigid bronchoscopy. And while passing the rigid bronchoscope, we mechanically debulked some of the lesions which were there. And after this, a silicone stent, a Y stent was put in so that she has an adequate airway, both the larger airway, the trachea, as well as the right and left main bronchi. Both were involved. And now this is what we got. And the patient was extubated on the same day. And yeah, the upper lobe, the lower lobe, and on the left side as well. So she was very happy because she was able to sleep down after 7 days flat on her bed. So yeah, we look at a. Okay, this is interesting. It's a 12-year-old boy who presented with complaints of off and on cough with expectoration for 1 year, not to us, but to the pediatric department. He underwent right middle and lower lobectomy in 2018 at CMC because he was getting recurrent infection causing right lower lobe collapse. So a CT was done for this patient, and this showed you can see a foreign body there in the intermediate bronchus. Let's see in this one, the white thing which is seen in right side. So this patient was taken up by the pediatric surgeons for the removal of the foreign body. And when they went in, they saw this was the picture of the right intermediate bronchus. So we have to understand there is no right middle lobe, there is no right lower lobe, right upper lobe is there, and right intermediate bronchus is thought. Where is the foreign body gone actually? So that was the time when we were called into the theater to see where is the foreign body. So we could make it out that this is all because of the foreign body which was present there, probably for an year because he was symptomatic. It has caused severe inflammatory reaction and has caused lots of inflammation so that the foreign body is walled off completely. It's all fibrous tissue. What we did was, again, we took the knife, the electrocautery knife, and we cut through this fibrous tissue slowly, gently. And then we could see something black popping out. That was the foreign body, which was then removed with the help of a rigid forceps. So, yeah. It was the central part of the whistle, the one round kind of a thing, which the child, and they don't remember having aspirated that. So this was the thing which was removed. Okay, so coming to the airways, IP has certainly changed the way the patients are managed nowadays. We can prevent lots of surgeries. We can do a palliative treatment, and we can actually save the life at that point of time. So apart from central airway obstruction, foreign body removal, there are bronchoscopic management available for the fistulas. Now, TOF, tracheoesophageal fistula, of course, the best treatment would be, the definitive treatment would be the surgical repair. But in patients where it is not possible to do, or the patient is not fit for surgery, a stent can be placed in for the time being, while the patient gets little better to undergo surgery, or if the TOF heals. Then there is bronchoscopic LVRS for COPD, which means lung volume reduction surgery for COPD patients who have hyperinflated lungs, emphysema, and you have given the maximum medication possible, but still patient is symptomatic. Then what is next? There are endobronchial valves, which is not available in India, but bronchoscopic thermal vapor ablation is available, not at our center, but it is there in Hyderabad. So I will just skip this video, and if we have time, we will run through so that you know how we do it. It's nothing. How do we do it is we passed a catheter through the bronchoscope into the diseased lung. You have to identify those areas after with a CT scan done properly. And then with that catheter, precise dose of thermal vapor, water vapor is delivered, which actually causes the inflammation, scarring, and it causes the inflammatory reaction, the scarring, and that area becomes small. So that is how what is the principle behind doing this bronchoscopic LVRS for COPD? It improves the lung function and physical performance. So far, around 12 patients have been done at Yashoda Hospital, Hyderabad. The cost is an issue because one catheter costs around 2.5 to 3 lakh, and it can be used only once. This we will play later. Coming to the mediastinum, my 18-year-old girl with complaints of dry cough, feverish feeling, and weight loss. CT thorax was showing mediastinal adenopathy. She has done EBUS elsewhere, which was inconclusive. So when she came to us, there were large nodes actually, and we were wondering, should we do an EBUS FNAC or should we, because elsewhere it is done, should we do? What we did was we did a transbronchial nodal biopsy, and we used the cryobiopsy. So cryobiopsy is the technique which uses cryo or the freezing technique. You pass the, wherever you have to take the biopsy, you hold, it freezes the area around it, and you get a big chunk, which is actually well preserved. And it is not, when you're taking with the biopsy forceps, it can be crushed, but this is uncrushed sample. For her, the histopathology was lymphoma. So mediastinum, EBUS, the advent of EBUS has obviated the need for mediastinoscopy, which was some 20 years back that used to be done. Apart from doing diagnostic and staging EBUS for patients with malignancy who, or lung cancer or any malignancy who are for surgery, it is a very, very good option. Diagnostic yield is more than 95%. But if you're suspecting lymphoma, because the yield of TBNA reduces significantly in patients with lymphoma, or when you have done an FNAC, which is negative and malignancy is highly suspected, then it is better to do the transbronchial nodal biopsy to get the better tissue sample as well as the diagnostic yield. Look at the clinical case 9, a 57-year-old male non-smoker, predominantly dry cough for 1 year. He has history of ATT for 6 months based on radiology locally, and that was before that. November 23, visited CMC. There was BAL and TBLB done, inconclusive, treated as infection because BAL showed a staph. Then in May 24, again came. This time again BAL TBLB was done, which was suggestive of OP pattern, was given on steroids, had some improvement, but in October 24, again came with worsening cough for 1 month. So this is the X-ray from November 23. This is the X-ray from May 24, and this is the X-ray from October 24, and this is an HRCT for this patient. So what should we do next? If there is a patient whom we have done the biopsy twice, and the lesions are persisting and patient is symptomatic, what is the next thing? I think we should go for the surgical or an open lung biopsy. But what we did was, we can see there's quite a bit of ground glassing giving a crazy pave appearance, and then there is dense consolidation in the middle lobe and the lower lobe. What we did was we did a cryo-TBLB on this patient, and it came as low-grade non-Hodgkin's lymphoma, right? So cryo-TBLB, as I said, again, how does it help is it gives you a bigger tissue because it freezes the big tissue, and it has actually obviated the need for doing surgical biopsies in lots of research in patients with DPLD or the ILDs if it is needed. So look at the size of the tube, and I'll just put a comparison. The above one is the normal bronchial biopsies, which we take with the simple biopsy, and this is the cryo-TBLB specimen. So that's the difference. So apart from in parenchyma, if we are talking about, apart from cryo-TBLB, lots of research and innovation has happened where how you can target the peripheral nodules. I'm not going into the detail of this, but radial EBUS guided biopsy can be done where the radial EBUS is something which has a radial probe where the ultrasound probe moves circumferentially. So you can go up to the, with the newer scopes which have come up to the 8th subsegment also, 8th generation segments also. You can place there, see if the lesion is there, and from there you can do the biopsy. Plus there are lots of navigation tools like navigational bronchoscopy, which guides you to each and every subsegment that this is the place where you can go. CBCT is there, cone beams CT, and robotic bronchoscopy. So at CMC, we don't have these navigational tools, but over and above, everything is available in CMC in both the campuses. And the future is actually ablative therapy. So you see a nodule, you go that you diagnose that nodule, go to the, with the navigational tools to that area, biopsy, do a imprint cytology on at the site. It is malignancy. You same time you do a ablative therapy and the treatment is done. So that is going to, the future is going to come a big way in another 1 or 2 years. These are my, okay. 39-year-old male non-smoker who presented with complaints of loss of weight and appetite of 3 months and exertional dyspnea for 45 days. General examination was unremarkable other than he has low BMI. What I meant to say unremarkable, he didn't had any peripheral lymphadenopathy or organomegaly. This was the X-ray for this patient. So anything abnormal on this X-ray, if we could see? It's only the blunting of the left CP angle, right? A CT was done. In the interest of time, I have just reduced the area where we are interested in. So this CT scan was done, CT thorax and abdomen, which was essentially normal, except what we are seeing in the left lower zone, a sliver of fluid, a small fluid, but then the pleural thickening is not there. So what should we do next is the question I would like to ask from the house. Anyone, quickly. There is a thin sliver of fluid. Ultrasound said it is very thin actually, and pleural thickening is also not there. So CT guided biopsy was asked by the radiologist, but they said pleural thickening is not there and it's very small. They won't be able to do it. And then what we did is a medical thoracoscopy. So I understand that pleuroscopy or medical thoracoscopy is being done, and all of us know it is done for undiagnosed exudative pleural effusion. But if you have very minimal effusion, or if you have no effusion, but pleural thickening only is there, or pleural based nodules are there, thoracoscopy can still be done by doing an induction of the pneumothorax. So this patient, we did the thoracoscopy, and to a surprise, these were the pictures we saw, which was not seen on the CT scan at all. So these were biopsied, and it came as tuberculosis. So treatment sorted. The last case is a 40-year-old gentleman, ex-smoker, presented with complaints of cough with expectoration, exertional dyspnea for 1 month, diagnosed as pulmonary tuberculosis locally, started on ATT for 3 months. So he had clinical improvement, was partial, and he had some worsening radiology. Unfortunately, he didn't got his X-ray. He came, the doctor has told that the X-ray is not improving. Now, this was the X-ray at presentation to us. What are the reasons why the patient will not improve if he is taking ATT? Suppose it is TB and patient is taking ATT, especially in effusions, if it is there could be a possibility. One thing, that this is not, the pleural effusion has actually converted into empyema. That may be the reason. Second thing would be it is multisaptated, and that is why it is not improving. Third thing would be whether it is really susceptible TB or it could be resistant TB as well. And then there are other things which comes up, like the assays you have to do for the, look at the, the levels of the drugs. If that is not proper, that has come out to be one big reason why the patient does not improve. So he was referred, and that is what the X-ray was then. We did an ultrasound. We don't do the CT scan straightforward. We did an ultrasound, and this was the ultrasound. And I think all of us can make out this is really MASH, which is sitting in the multisaptated, loculated and multisaptated effusion. We took the challenge of doing the thoracoscopy. It was a therapeutic medical thoracoscopy for adhesiolysis. And this was, as soon as I entered, this is what it was shown in. We continued doing clearing. And finally, we were able to see the parietal pleura, the costal pleura, and we further cleared it. We take the biopsy, came as necrotizing granulomatous inflammation, and expert was RIF resistance. So there were multiple reasons for this patient not to improve. One thing was multisaptated effusion, and second thing, he was having resistant tuberculosis. This is the post-thoracoscopy X-ray, and that is 6 months on ATT for resistant TB, all oral bedaquiline resistant regimen he was taking. 6 months follow-up. We don't even know that whether the thing has happened. If we would have left this patient, it would have been organized, and he would have left with, dense pleural thickening requiring surgery later. So do we do therapeutic thoracoscopy for all patients? No, there is an indication, stage 1 or stage 2 paranemic effusions or empyema. It is beneficial. And also the newer thing which is coming up is if daycare, and that we are doing it. So daycare thoracoscopy is the patient gets admitted in the morning. We do the procedure. We do a imprint cytology, which is a very quick thing, making the slides, send it to the pathology department, and they tell us whether it is malignancy or it is granulomatous disease, or if it is another diagnosis. We also do the CB-net, which comes in 2 hours. We get the diagnosis, and based on that, the patient gets discharged on the same day or within 24 hours. So if it is malignancy, we do the pleurodesis at the same time, and next day morning, the tube is removed, patient goes out. So I wanted to say that medical thoracoscopy is feasible with minimal or no effusion also, but only in expert hands. So concluding, innovations have certainly transformed the landscape of how do we care our patients. And with continued research and innovation, IP has the potential to transform the lives and redefine the field of respiratory care. So just wanted to say, in 2000, when I got selected my branch as TB and respiratory disease, all people used to say us as TB ka doctor, but the things are changing. And yeah, so this is for me. Thank you so much.
Thank you very much for that phenomenal presentation. I think very interesting and educative series of cases. And it's good to see that you can diagnose most pleural effusions with a biopsy. We used to do pleural biopsy cultures and send them for AFB earlier, but now you can look at it and then biopsy it. That's remarkable. Thank you very much. Questions from
To add that interventional pulmonology is a teamwork, actually. It is not that I'm the one who is doing it. Has to be a really, really teamwork, and our RTs are phenomenal, and my team as well. I just want you to give a clap for the team who is sitting there. Can everybody get up, please? Our team of, yeah, department. Thank you so much.